is Dr. Shannon Virtue. I am one of the psychologists at the Helen F. Graham Cancer Center and Research Institute, which is part of Christiana Care. I'm going to be talking today about exploring comorbid diabetes and breast cancer and my journey from MRDA to pilot. So I'll be talking about the project, but also just about the steps in the journey that I got to with the ESSEL pilot grant that I currently have focusing on this topic. So first step to getting to the pilot, where did I start? Well, it started with a research idea. And how did I get that research idea? It was really a combination of both clinical experience and delving into the background literature and research. In terms of the clinical experience, I'm a health psychologist, so I'm working at the Cancer Center, working in a clinical setting with oncology patients throughout their cancer experience and their cancer journey. And I started to notice that there were a number of folks when I was meeting with them, even though it was in the context of their cancer experience, were sharing with me about some of the burden that they have just managing other chronic health conditions in the context of a cancer diagnosis. And this pull to put other health conditions on hold to focus on the cancer, or just receiving kind of misinformation about how they should be navigating multiple health conditions at the same time. And this specifically came up around diabetes and diabetes management. So folks talking about, I think I can eat all the ice cream that I can now while I'm going through chemotherapy treatment because I can't lose weight, but this is really counter to what I've been told about my diabetes management all these years. So having a lot of uncertainty about how to navigate both of those. Folks sometimes actually during their cancer experience being hospitalized for reasons related to diabetes management. So clinically, I was hearing a lot about this, a lot of just change in how they were managing their diabetes. And for me as a health psychologist, this is also kind of clicking, well, what happens when the treatment stops? Because what we know is that the expectation that even if someone has some lapses in their diabetes management behaviorally during cancer treatment, the expectation that they'll just go back to what they were doing before is not really a reasonable expectation. So this was starting to stick out to me. And so I said, let me delve a little bit into the literature and see what do we know about comorbid diabetes and breast cancer. I'm focusing specifically on breast cancer, though that's not to say that this wouldn't apply and I think wouldn't be worthwhile to explore this in other types of cancers as well. So what I found when I delved into the literature more is that about 16% of individuals who are diagnosed with breast cancer also have a diagnosis of type 2 diabetes. And there is a really good solid background of existing research that focuses on those two conditions, specifically common risk factors, underlying biological processes. There's also a host of research on the impact that having diabetes might have on certain cancer outcomes. So I saw all that literature, but what I noticed missing was, what about the patient? There really wasn't a lot of literature looking at things like patient-reported outcomes. There also was another gap that I noticed in the literature was what I had just talked about a moment ago, the behavioral management of the diabetes. So really understanding from a behavioral standpoint, what are folks doing? What are the actual behaviors they're engaging in to manage their diabetes while going through cancer treatment? So these gaps were identified in the literature. There was a systematic review conducted in 2016 that actually highlighted this as one of the gaps in literature, specifically kind of the patient-reported outcome and the patient perspective. And then as well as some gaps, like I said, with the behavioral management. There are a very, very small number of studies that focus on diabetes management during cancer treatment. And in those small studies, they did notice that the conclusions from those studies were that diabetes management behaviors tend to decrease during cancer treatment, and that they do not necessarily return to their baseline levels after treatment. So great, I thought this is a great research idea. I'm going to go ahead and submit it for a pilot grant. So I initially submitted a pilot grant with my research aims focusing on examining diabetes management behaviors among those undergoing treatment for breast cancer, and to identify any factors that are related to changes in diabetes management. Trying to look at what are maybe some risk factors or factors that we want to consider when looking at any potential changes or lapses in diabetes management. And what I learned was, well, what I thought was a good research idea, that having a good research idea doesn't always automatically translate to grant funding. So I did not initially receive funding for that pilot grant application. So what does that mean? Does that mean we just give up the research idea? No, it was back to the drawing board and thinking about what were some next steps that I could take. And so I was very fortunate enough, had some guidance. So, have you thought about the Mentored Research Development Award, the MRDA award? So I looked into that and I thought this looks great. This looks, hopefully what can really be the next stepping stone for me. So I submitted for the MRDA and was fortunate enough to receive the MRDA, which gave me time to really focus in on some things to help my project get to the point where it could potentially receive some pilot funding. So I used the MRDA to get some mentorship in grant writing mentorship. I worked with a mentor, Dr. Allison Carpin from the University of Delaware, who was able to help with grant writing mentorship, as well as just helping educate myself on the community engagement piece of the research. So a big gap that I was identifying was the patient, but really understanding what does that mean doing research that is focusing on the patient and really thinking about kind of the community that we're serving with this research. I also just I used it to increase my knowledge base. So I was able to participate in a mental health provider diabetes education program, just to increase my knowledge more on the diabetes front. Working in oncology, I had a background there, and I had some background in diabetes, but felt like that was maybe a learning gap for me that I could close a little bit. And then I was also able to use some of the time to just get some really, really small data collection to just kind of help see with these ideas that I was thinking if they were kind of pairing out a little bit in the data. So we did a very small study just to get some preliminary data, and we looked at, which just was a one-time cross-sectional survey. And we looked at folks who had a diagnosis of cancer and also a diagnosis of diabetes, and we had them rate the frequency that they engage in certain recommended diabetes self-care behaviors. So as you can see from this table, we started to notice that they weren't. There were some folks that were engaging in the things that are recommended. So checking their blood glucose. Carrying quick-acting sugars for, to treat any kind of low blood glucose, exercising. However, there was also a good portion of folks who were not. So the majority, if you notice there from the numbers, were exercising sometimes, rarely, or never. A good portion of folks never carrying quick-acting sugar to treat blood glucose, which again, kind of going back to how I came to this research question with folks sharing with me, I think this was an important one that stuck out to me because I was talking with folks who were experiencing low blood sugar, hypoglycemic episodes during their cancer treatment, and this was unfamiliar to them. They hadn't navigated that before. So this was kind of from the preliminary data starting to see what we had hypothesized a little bit in terms of some of the management behaviors. We also just in this preliminary data did a quick screener for psychological distress, just with wanting to kind of get a quick picture of that. As we know, kind of separately, psychological distress can be related to diabetes and diabetes management. So wanting to see if this was coming up and if that could potentially be a factor. So we did see, at least in this very small sample size, that a good portion of them were indicating some clinically significant depressive symptoms, as well as a good portion of them who were indicating some mild, moderate, and even severe anxiety symptoms. So all of those things through the MRDA took me to my next phase in the journey, and that was going back to submitting another application for a pilot grant. So based on some of the feedback, some of the work that I did through the MRDA, I tweaked a little bit in my aims. I still, again, am hoping to achieve a better understanding specifically of the diabetes management behaviors during breast cancer treatment. also continuing to look at some of those factors that are related to diabetes management behaviors during cancer treatment. And we added a third aim to do some additional qualitative analysis. So to get some patient-reported data where the patient is able to share their experiences in terms of managing their diabetes during their cancer treatment. They're able to speak to what the challenges are, what the support needs are. So we added that aim into the application. And again, just as I mentioned, we're proposing to do both quantitative data with the surveys looking at the management behaviors across 3 time points, so trying to get a little bit of a longitudinal look at this, as well as the qualitative data. So fortunate enough, submitted this application and did receive funding for this pilot. So currently, we are engaged in this project, in this research. We're currently recruiting and collecting data. At the time I put these slides together, we had 7 women who were enrolled to complete the longitudinal surveys and 5 women who had consented for the semi-structured interview, the qualitative data. Since that time, these numbers have gone up, so we've had more women sign on to do the surveys, and we've actually completed 7 semi-structured interviews getting the qualitative data from the women. So we're moving along with the recruitment and with the data collection as part of the pilot project. And so my hope is, in this journey that I'm talking about, that it's not, this isn't the end, that the pilot isn't the end, but really kind of thinking about what the next steps are beyond there. So I'm really thinking about dissemination of these findings. How do we share this information once we get to that point? And how do we build this program? So really looking at this pilot as another stepping stone for further research with larger sampling, get kind of more data across breast cancer treatment, getting additional types of data. If we can also get some data more specifically on A1C and other things like that, since we're just doing the surveys with this. As I mentioned before, even thinking about expanding beyond breast cancer. So building the research is kind of one of the next steps that I see, but then also from a program development standpoint, how can we use this information, hopefully that we'll get to really have a patient-informed approach to helping folks manage both diabetes and cancer and that whole experience. So that is an overview of the project and really the journey that I took to get to this project and hope to continue.